I first got interested in using naltrexone to treat alcohol use disorder in the late 1970s. And I was an MD, Ph.D. student at the University of Pennsylvania. And on one of my clinical rotations, I met a patient, a veteran from Vietnam, who had severe alcohol use disorder. And when he was in Vietnam, he had periods of sheer terror, followed by periods of boredom. And many of the people who were in Vietnam at the time would use opiates during the times of boredom. When he came back to the United States, he didn't have so much craving for opiates, but he developed excessive alcohol drinking. And I wondered why, if there's some relationship between opiates, stress, and drinking. And I went back to the laboratory and I started doing research with rats. And I found that rats that were given uncontrollable trauma would also increase their drinking of alcohol, particularly after the stress. And then I did a study with rats where I showed that naltrexone could block the post-stress drinking. Went on to do my residency in psychiatry. And after I completed the residency at Penn, I joined the faculty where I started the first study at the Philadelphia VA. And we found in a placebo-controlled trial, if you gave people naltrexone, it blocked their craving for alcohol. If they had a slip, they reported that they didn't get as high as they normally get when they drink. And what we found is that liver enzymes were lower, they had lower relapse rates. And it was really interesting to me because it's pretty rare in psychiatry that you can find something that works in human trials that derive from animal research. So we were really overjoyed with the results, and we spread the results to everyone we could tell. And some of the folks that we spread the results to were the folks at Yale, who were going to conduct a study looking at an SSRI to treat alcohol use disorder. But after they heard about our results, they switched over to naltrexone. And so Stephanie O'Malley and her group at Yale did a similar study. And they also found that naltrexone helped reduce relapse. When we first published the results, the academic community was very skeptical, but over time, I think because Stephanie found the same results that we found, we got some traction in the academic community that there was something going on with this naltrexone and alcohol use disorder. But from the very beginning, we didn't get much traction in the treatment community. The whole idea of using an opiate antagonist that would have some effect on alcohol drinking really didn't gain much traction. It and are willing to use it. Second, you need patients who are interested in taking it. And third, you need a treatment process that doesn't have barriers. So it's affordable for people, it's accessible, it's something that people can easily take advantage of. And in the early days of naltrexone, there really wasn't much traction in any of those three areas. That most healthcare providers were, number one, not interested in treating people with addiction. And if they were, they never heard of naltrexone. The whole idea of using an opiate antagonist to treat somebody with an alcohol problem didn't really make sense to them. In medical school curriculum, they don't learn about addictions very much. So when they came out and did their practice, they weren't really looking for people who had alcohol problems, and they weren't aware of the medicines that they could use to treat folks. And then in the general community, even now, if you ask people about naltrexone, most people have never really heard of it. The idea, again, of a medicine to treat addiction doesn't make sense. It doesn't necessarily follow from the AA model, in which the primary disorder is a disorder of some defect in your character, or as VA calls it, it's willful misconduct. So the whole idea that it's a medical disorder really didn't make sense to people, so people aren't looking for any medicine to treat it. And then the third factor is, if you look at the treatment community, it's really not set up well to treat people with medicines who have addictions. If you look at insurance reimbursement, for example, there's like two silos of reimbursement, that for medical disorders and that for behavioral disorders. And we set up a program, for example, and I hired a primary care doctor. And when we tried to bill for the treatment for our patients in our addiction program. We found the insurance company wouldn't pay for her visits because she was not a psychiatrist. She didn't have special training in addiction. Some of our patients, particularly in the early days, didn't have medical coverage to treat addictions. I think that improved with the Obamacare, but still that seems to be a big challenge. I think in the early days, naltrexone was reasonably expensive. Percy, you can maybe talk to that. The Revia, I think, was.
Yeah, it was like $3 or $4 a pill.
Yeah, so $4 a pill times 30 pills a month, starts adding up a little bit. And so that was a barrier for people just to afford paying for the medicine. So all these barriers together, I think, created an environment that wasn't really right to adopt the use of naltrexone. And we can maybe speak later to this, in terms of where we are now. I'm not sure we made that much progress toward that. The short answer is yes, but let me go into some detail with that. The problem with addictive drugs is that use creates the desire to use more of it. And naltrexone, I guess, is the first medicine that sort of breaks that addictive cycle, that you can drink alcohol and it doesn't increase your craving to have the second, third, and fourth drink. And so it's really uniquely suited to be a medicine to help people who want to moderate their drinking and not completely abstain. And when you look at people who have alcohol use disorder or even drink excessively, you find it's a wide spectrum. So it's hard to say that there's one treatment that's going to work for everyone. A lot of times when we think of people with alcohol use disorder, we think of people on the severe end of the spectrum, the people who've lost their families, relationships, their jobs, their health. And those folks often have physical dependence on the alcohol. And for people who are at that end of the spectrum, usually I recommend a period of abstaining from the alcohol to completely detoxify from the alcohol, and then use naltrexone in a daily way to help maintain their sobriety. But there are a lot of people who are at the moderate or mild end of the spectrum who perhaps they drink a lot on weekends, that they, when they start drinking, they have trouble controlling how much they drink. And their goal is not to completely abstain. And that would be a barrier to even getting any kind of help because that's not what they want. But if they take naltrexone before a drinking episode, they find that they can moderate their drinking. They can easily stop after one or two drinks, and they're really happy with that outcome. And I have many patients who that is their goal for treatment, to moderate their drinking. And they take the naltrexone in a targeted way or before they drink, and they do perfectly fine. And they've been doing that for years, and the drinking hasn't escalated. For many of them, they find that they do lose the desire to drink altogether, not because they should, not because they have to, but they just don't want to anymore. It's not that they even miss the alcohol. It's just something that they don't do anymore. And so the naltrexone was a good conduit to get to that stage. If you'd asked them to abstain early on, they would say, no, I'm not going to do that. And so there's many ways to use naltrexone, not just for its ability to reduce craving, but it's really effective to reduce the high associated with drinking, and particularly to reduce that cycle where drinking creates the need to drink more. I knew David Sinclair, who came up with the Sinclair method, and in prepping for today, I actually ran across a paper that he wrote where he discussed different ways of using naltrexone to help people with addiction. And at one point in his paper, he said that he came down to visit Volpicelli's group at Penn and talk to them about his approach, which is to use naltrexone in a way in which you take the naltrexone at about an hour before drinking. And it's important that you drink, because when you drink with naltrexone, you don't get the reward from alcohol. So that should extinguish the drinking response. And way back in the 1980s when we met, I said, well, you know what? Naltrexone can work in other ways as well. It can help reduce craving, and also it helps reduce that addictive cycle where one drink creates the need to have the second drink. So I don't think you have to drink to get beneficial effects. So we went back and forth on that. But his method is really designed to use naltrexone about an hour and a half before a drinking episode, and drink, and then discover that you don't get the reinforcement from the alcohol. So people use naltrexone in that way. And many people report that it's very helpful. And if you like, I can talk about some of the conditions where I think it's especially helpful. But other people will take naltrexone before they go into a high-risk situation. So people maybe have had months where they haven't had any drinking, but they know that they're going to a wedding, or they're meeting up with friends at a tailgate party or something like that. And they know that that was a situation that often preceded drinking, and they wanted to not have craving for that episode. So they would take naltrexone before that so that they wouldn't experience the craving. And other people will use naltrexone not for extinction, but just so they can go to a function and keep their drinking under control, to keep it to 1 or 2 drinks. And so naltrexone has a variety of ways of people using it. And it's perfectly acceptable to use it for any of those ways, including not having a goal of complete abstinence. Yeah, those barriers to treatment that I talked about, I'd like to do something to help change those. So, for example, it's really important to get the word out to people that there's an option available besides, going to AA or going into a rehab program. And I wonder if hopefully programs like this, talking to more community members, that there be more of a sort of a grassroots effort to get the word out. Like as Josh says, there's no patent for naltrexone anymore, so it's unlikely we're going to get much of a marketing campaign from some pharmaceutical company. So I think the impetus is going to actually come from the community. And there's a couple things that give me encouragement along those lines. Number one, I know that there's a Reddit subgroup called Alcoholism Medication that has over 20,000 members now. And just for fun, I Googled naltrexone by looking at Google Trends, and it's actually been increasing over the past 5 years, which is different for things like buprenorphine, which is actually decreasing a little bit, and other medical treatments for disorder. So there seems to be increasing interest for people wanting to look up naltrexone. There's interest in communities which are set up to use naltrexone. So I'm encouraged that there's some traction now in the general community to use naltrexone. So that's number one. Number two, I'm encouraged that clinicians are more interested in using naltrexone. And I'll give you one example. I know a few years ago, Percy, I think you received a letter from a reporter from the director at Betty Ford's. And the letter basically said, we don't believe in naltrexone. We don't believe in using any psychoactive medicine. We're never going to use naltrexone in our patients. And that was, I think, in 2008 or something like that. So anyway, I was upset when I saw that. So I wrote a letter, sent an email to the folks at Hazleton, and I said, what's your view about using naltrexone now? So first letter I got back was from their public relations person. Says, oh, we looked you up on Google and we think naltrexone is a good option. But then I got a letter from the medical director there who said, oh yeah, we use it all the time. That when people leave, we give them extended release naltrexone, and we really believe that it's an important component of treatment. And I said, well, they're still maybe blowing smoke up my rear end because they know I have something to do with naltrexone. But I relayed this story to some people who are in that a Discord community, and I found that one of the patients there, so one of the participants in this Discord meetup group, said, oh yeah, I was in Hazleton a few years ago, and they would not let me leave until I took a shot of the extended release naltrexone. So it's actually true. So if a program, very conservative program like Hazleton, can come around, I'm optimistic that other healthcare providers can come around. And then the third thing that gives me optimism is the barriers for getting naltrexone are decreasing. And Josh, I think you really pointed out that we're getting increasingly comfortable that this medicine is safe and can be used in a variety of settings, and you don't need very intensive psychosocial support. Now, I want to distinguish between psychotherapy and psychosocial support, and there's a reason for that. That for the original extended release study that Alkermes used to test their product, I actually designed the psychosocial support. And it's basically that Brenda approach, which was then used to be the medical management component of Project Combined. And Brenda was designed to help enhance adherence with taking the medicine. And that's the kind of support you need, not necessarily support to deal with people's psychological issues, although I think that can be very helpful for some people. But when you use naltrexone, I think it is important to use it in a context in which the clinician doesn't have to be a PhD in psychology to use it. Any clinician can use this very simple approach that we designed to help people get motivated to use the medicine and to stay on it. And actually, I designed this because I was frustrated in my clinical studies when people would drop out, and it messes up the study when I lose data. So I wanted to design a psychosocial treatment that involves the motivation enhancement techniques and that sort of thing to get people to stay on the medicine. And when you use naltrexone in that context, I think you get much better results. So it's not necessarily fancy psychotherapy. It's that kind of medical management that they used in Project Combine. So I'm encouraged that the barriers for treatment are coming down, that you don't need intensive psychotherapy to get it, that frankly, programs like you have at OAR, where people can, in the privacy of their own home, talk to someone to get a prescription delivered to their door, can be really helpful. The cost is pretty manageable now. And even if you don't have a doctor nearby, you can use telehelp now to get access to naltrexone. I think all these things are encouraging to help bring the naltrexone directly to people who are interested in using it. So, I would just like to add that for people who've had been frustrated that they haven't been able to get better with traditional treatments, that this is a really good non-traditional approach to really break that addictive cycle and help people be freed up and recover from this disorder.